You do the recording, please, and keep a recording for that.
Yeah, I keep recording it and place it on the Facebook, also on the Instagram and channels. Yeah, they can see it at another time, because now we have so many webinars these days and overshadowing each other. So many.
Yes. So many webinars now.
Yeah.
There's, and now during the same time, there's a very big webinar also for Mike Picos.
Yes.
So now, at the same time.
Okay, let's start. Hello, everybody. It's a pleasure for me to be with you in this another session of Implant Diary, and with amazing Dr. Emad Salloum, very well known, very well regarded maxillofacial surgeon, and there is no need to introduce him. But as a routine in this kind of webinars, let me introduce again Dr. Emad Salloum. Dr. Salloum graduated from dental school, Damascus University in 1981, where he completed his residency program, postgraduate program in oral and maxillofacial surgery in 1986. And also external fellowship training and Emory University and Emory Clinic 1989, 1992, and 1998. He's also a diplomate of ICY, a board member of Syrian Association of Oral and Maxillofacial Surgery, and editorial board member of Syrian Association of Implant Dentistry. Dr. Salloum is an international ambassador for ICY and an international ambassador of Digital Dentistry Society. He's also a speaker for British Academy of Implant and Restorative Dentistry and international expert on dental XP. Dr. Salloum had been lecturing several congresses, regional and international conferences, symposiums, and published several clinical studies and articles. And Chief Surgeon and Director of Salloum Dental Clinic and Training Center. Welcome again, Dr. Salloum. It's a pleasure to be with you in this Implant Diary session. And as I mentioned before to all of our participants, Implant Diary is talking more about visions and concepts instead of methods and techniques, because there are so many techniques, webinars, and methods in this time. Yeah. You can find it, but talking about the vision and concept of that well-known and well-regarded surgeon, implant surgeon, is more important as his technique. We want to talk about this. Also, we have a presentation about advanced augmentation, bone augmentation techniques with Dr. Salloum, after a chat about his concept and his vision about especially these times of crisis that all of us, many of us confined to our home and experiencing different type of lifestyle. Okay, welcome, Dr. Emad. Hi. Can you hear me?
Thank you. Thank you, Mr. so much for hosting me in your everybody's in a little bit. I don't know if the connection, I think. Okay. Everybody is hearing me well? Mr. Are you with me?
Yes, yes, yes. But your voice disconnected for a moment. Okay, we have you.
Oh, so much again, Mr. for hosting me in your excellent platform with the good concept of making concepts and ideas more than techniques, which is the most important, I think, for every dentist. Thank you again for hosting me, and I hope that everybody will take the benefit of this short presentation. I want to make it short, just a straightforward idea to show not a technique, but a concept of how would I prefer to do with bone augmentation cases.
Great,
And I
great.
share my screen now. Okay.
Uh, uh,
So we don't lose, so we don't lose time.
mhm.
Okay. Can you please allow sharing my screen? Put me a host, please.
Let me ask some thing about this crisis in your city, in your country, just right now, and then after 10 minutes,
Okay.
maybe you go to the
Yes,
presentation.
it will be a
How
pleasure.
about this
Yes.
situation affect your practice, your city, your country?
Well, thanks God, until now, as a pandemic, we are not so affected.
Hmm.
Only 50 cases in Syria now had been registered. But
Oh,
still, we are taking all the precautions like everybody else in the world. So everything was total lockdown.
hmm.
We just opened 2 days ago, only 2 days ago. So we started back again in my practice only 2 days ago. So I think that it will be a very slow, uh, it will be a very slow start. uh, as you know, people have been affected so much, not only because they are afraid of going to dentists, or
Yeah.
maybe they are afraid to communicate with people, but also from a financial and economic, social economic point of view. Everybody was affected because a lot of people, they lost their jobs, a lot of people, they lost, especially the small business, they could not tolerate staying home for 2 months almost now. So I think that the coming at least 6 months will be a little bit tough, not for us here in Syria, but I think everywhere in the world, everywhere in
Yes.
the world. As you can see in the United States, in Canada, Australia, from east to west, north to south, everybody is suffering, and hopefully this crisis will have a happy ending.
Yeah.
I think that everybody in the world, even the researchers, even the doctors, even all the Medicare staff, they are, in my opinion, they are doing what we call a try and error. So
Yes.
now they just opened for here in Syria, at least we are opening for 1 month as a demonstration, and then we will see what's going to happen. I think that everywhere in the world, but we have to start uh, going back to our normal life so far. I think so.
Yes. Maybe another normal life, the different kind of normal life,
Yes,
because everything will
of
change.
course, of course. Yes, we will be go back to life, but not absolutely not as before. It will be totally different.
Yes,
I
yes.
I totally agree with you. Yes.
Uh, Dr. Ahmad, is any particular protocols you started for your practice, your clinic, any specific for disinfection or maybe a ventilator or something like that?
In fact, in my practice, the recommendations of the American Dental Association long time ago, there are disinfecting everything. Now we are taking a little bit more precautions. I mean, by the first thing is to assure the social distancing. So the waiting room has to be almost empty, just one appointment at a time. So this is the new trend now, one appointment at a time, cleaning and disinfecting all the chair or everything, all the surfaces between two, as Michael Stanley says, slow dentistry, which means we have to give time for our patients, time for our staff to do the cleaning. Thanks God, in my practice, I have 5 operatory rooms and a surgery. They have time to make this kind of change, but still but no ventilators or special. I have already a negative pressure ventilation system long time ago, so it's not a new thing. But the new thing is that strictly disinfecting everything, including surfaces, ground, chair, mirrors, everything between patients. In fact, we are not wearing this astronaut suit
Yeah.
yet, But yeah, but face shields, everything, caps, full gown. This is mandatory, and I think that this is going to be part of our daily practice way.
Uh-huh.
This is the new trend. I think that it will be going on for years and years, maybe forever. Now, the protocols mainly is training the staff with the new training of your staff. Now I've started to train my assistants in a different way, how to deal with the patients, even the receptionist, how to take the appointments far apart of each other. And I have to add some more assistants actually, because I'll be operating in 3 operatory rooms, so I need assistants everywhere to prepare and in the new protocols and let the patient dressed well. I cover their hair, everybody, and put some boots over there. It's a new protocol. We have to take it with our patients and with our.
But not like the astronauts, yeah?
No. When it comes, if I was obliged to do it, I can't work with this.
Okay, really. Yeah, you cannot do that.
Especially if you want to put loops and put all these, it's not practical.
I'm putting this on Instagram Live now, and Omid join and say hello to you.
Oh, Omid. Omid, it's a great pleasure to be with us.
Yeah,
I love this man. You know, he's a great friend. He's a great speaker. He's a great guy, and he's a
amazing,
open-minded, brilliant guy.
Yes.
Hello, Omid. It's so good to see you with us. Thank you.
Thank you. Yeah, I was saying that for economic situation, it's tough for patients, but for dentistry point of view, it's good to doing the dentistry very good and effectively. We have time for diagnosis, we have time for accepting patients
Absolutely.
In a very smooth position without any rush, moving from this chair to another chair. We have time to doing very well for our patients. From this point of view, it's going to be good. But for economics,
and the good thing, yes, and the good thing is I always now take a cup of coffee between each patient.
Yeah.
So I have all the time to relax between 2 surgeries, have a cup of coffee, and do it easy.
Yes. And doing effectively. Yeah, I like this kind of treatment. And okay. I love that the decoration behind you, because it's so similar to what we have in Iran, like this thing.
Yeah,
I like it.
Very similar. Yes, that's true. That's true. Yes.
Yeah.
Yes.
Okay.
Unfortunately, this year we're not going to Iran. You know that going to the Congress that has been organized by Omid was a trend for me. I go every year. Unfortunately, we are going to do it online this year and miss the opportunity to be in such a beautiful place.
Yes, me too. 2 years ago, we were together there.
Yes, I remember
that. Maybe next time. But this time you have the online symposium with Omid.
Yes, we will do it online.
Yeah.
But it feels so different when you are there, you know?
Yes.
With a lot of hospitality and a beautiful country you have.
Yeah. Thank you, Omid. Okay. And what about the ventilators? Have you used that? Ever used the ventilators? No?
No. Actually, it's not available yet in the market. And we don't know how much it will be effective. It's a high-speed vacuum, you mean, to put in front of the patient with the big bulk, so it can aspirate all the droplets or something. In fact, it's not available yet in our market. But I don't think that it's something controversial.
Yes.
It's something controversial. It's nothing proven that we have to do it. But I think from my point of view, just from my point of view, that some companies are taking more advantage of the situation just to market new things while it's not, there's nothing proven yet.
Yes.
There's nothing proven yet, but when it will be a protocol, we have to follow. But it's not easy to put all this in front of you when you have two assistants with surgeries or a operating room and all this bulk of ventilator covering. It will not be so comfortable to work. Maybe we get used to it. I don't know.
Yeah, yeah. We don't know too much about the virus, the situations, the protocols. We don't know very much about this.
As I said to you, everybody is going now in a mood of try and error.
Yes.
So things are changing every day. In fact, things are changing every day on a daily basis. We have new research, we have new even ideas, and new protocols are going to come over one time at a time.
Yeah, exactly. Okay, we disconnected from Facebook. Let me connect it again to the Facebook, and we start your presentation.
Okay, I'm ready to do that. I'm ready. Shall I share my screen now?
Let me a minute to upload it to Facebook. I don't know why we disconnected from Facebook. Let me 1 minute.
I think that Facebook participants will be more than the Zoom participants because
yes,
they are more used to it. But
yes, exactly, and also Instagram, especially for Iranian. Okay, a second. Okay, we are live now on Facebook again. Okay, let me make you host.
So I can share my screen.
Yes,
just
you
let
can
me
share your screen. And yeah, my friends, the topic is about advanced bone augmentation and material used based on Dr. Salloum's concept and vision. Okay, perfect.
Everybody can see it well? Okay.
Yeah.
I'll just start. This is the first slide. I would like to thank you again, Mizyar, for hosting me. It's a great pleasure. In fact, I feel bad that we are meeting now from behind the screen. I would love to see you and hug you and see everybody there. It's a totally different feeling when you are on stage and doing a presentation. But well, according to our lockdown and with this horrible virus, but we have to face it. Thanks God we have all the facilities to go online on the internet and see each other and to share our ideas and knowledge.
Thank you.
For the people who don't know me, this is my place in Syria. I live in a beautiful city on the Mediterranean. It's called Tartus.
Emad, may I stop you for a moment? You can put the play option and you full screen it. Go up and click on play on your PowerPoint. See it?
I am, in fact, I'm on Mac, so it's a keynote.
Okay, you can keynote. Okay, you can play it. Play.
Yeah.
Click the play button over there.
Yeah. So, here. Yeah. Okay.
No,
here.
No. On the taskbar.
Yeah.
Taskbar, go beside the record and view thing. Up
beside
left.
The record.
Up left. Up left.
Yeah.
See that play? Go left. Go left.
Go
left. Text.
Stop video.
Forward. No. The play option.
No, there's no play option on my.
Yeah, you can make it full screen. It's better.
It's a full screen now. It's a full screen. My presentation is on full screen.
Yes.
Okay.
Did you click it? Okay.
No.
Okay. Okay.
So,
Let's go
so
forward.
okay. So
Sorry.
this is
Okay.
my place. It's a beautiful city on the Mediterranean. It's called Tartus, and I hope everybody will have the chance to come and visit me. I will be more than happy to host everybody and work together and share ideas and knowledge in my clinic. Well, as much as the subject is so big, so I'll try to be attached to what Winston Churchill said, that a good lecture or a good speech is like a woman's skirt. It has to be long enough to cover the subject, but short enough to create interest. So I'll try to be stuck with this verse, and hopefully my presentation will be of an interest for everybody. When I mean advanced bone engineering, in fact, my concept, or it's not my concept, but the concept I am going to present today is the biologic bone engineering. As we all know that the alveolar bone is the only unstable bone in the body. All the long bones in the bodies are stable, except the alveolar bone, which may undergo dramatic or very big changes during life. And it's because of and those dramatic changes are mainly from the extraction that we do. So it will, the bone will be resorbed, and according to Schraub and Cardropoli and all the workers, they said that we lose 40 to 60% of this bone after extraction during the first 2 years. So all the dentists will be facing, especially who are placing implants, they will be facing such cases of low height ridges, narrow ridges, or whereas there's a lack of bone with the high aesthetic demand. As we all know that in the anterior region or the aesthetic zone, even a loss of bone of the contour of the or of the width of a 1.5 millimeter is enough to be recognizable, and it will interfere with the placement of our implant as a final aesthetic outcome. So we have to deal, all the dentists, they should be dealing with those cases, and I'll show you now why. I mean the general dentist. I will start with some stories, just simple stories from my clinic. A patient here came to me, referred by his dentist. He is a general dentist. He came with his patient asking me to take out this implant from the maxillary sinus. So it was a complication he made at that time. It took me 25 minutes. Okay, I took this implant out. After sitting with my colleague, after the patient left, I told him, well, the easiest thing is that you had this implant in the sinus. You did all those implants in a non-correct distributed way. Why did you put those implants in this manner? As you can see here, there's implant on the left side with non-implant in the opposing side. All the distribution, those implants are unrestorable almost. You cannot do a nice prosthetic work with those implants. And his answer, and he had only one answer. He said, I'm sorry, but I placed them this way because I didn't have bone. I only had bone in those sites. And that made the click in my mind. Another case came to me maybe 5, 6 years ago. As you can see here, I wanted to show this picture. The patient is in almost total centric occlusion, and she is occluding on a one side only, where there's a cantilever on this side, and there are implants here on this side. She went to the dentist. He placed 6 implants, but he couldn't restore a full mouth rehabilitation. I asked her dentist, Why didn't you take advantage of those and putting those in the correct positioning? The same answer was that I didn't have enough bone in those sites. What an excuse. Some cases from the table of my lab technician, he was taking my advice. What should I do with those cases? As you can see, almost those cases are very difficult to be restored. Almost this case is unrestorable. And when I asked the dentist who sent me the case for a consultation, why do you do it this way? The same answer was from all those doctors. They said that we didn't have enough bone. This is the fourth case I want to share with you. This patient came to my office in a very desperate case. She was dreaming, she is only 40 years old, and she is dreaming of a full mouth rehabilitation with an upper implants. And because she was so afraid, so she went into general anesthesia with her dentist. But her dentist was only able to place 4 implants. When she came to me for a consultation with her dentist, the same answer was from her doctor that I placed my implants where only I had bone. So this case was underestimated before surgery, and she went in only 4 implants. That made a click in my mind that I should do a special program or a special series of lectures about managing implants in compromised bone. And those lectures are oriented to the general dentists. They are not for the periodontists, the advanced guys of periodontists, or oral maxillofacial surgeons. I want the general dentists to be oriented in how to deal and how to manage implants in compromised bone. Why? If you ask me why, I would say that in 70% of the implants that are inserted in the mouth in the whole wide world, 70% of them are placed by general dentists. They are not placed by specialists. And this is a fact. And they are able to do those kind of implants. And in fact, another fact also is that 80% of our patients, they don't have an ideal bone. They come to our clinic after 2-3 years after extraction, which means that they have already lost such an amount of bone, which means 80% of the cases, they are not ideal and they lacking some kind of bone. With more aesthetic demands from the patient and more aesthetic demands even from the dentist, with all the improvement in the graft material and with all the minimally invasive techniques, the general dentist should be highly involved in even understanding how to manage the alveolar bone deficiency, because in fact, they are the first line who are placing the implants. So my concept is to be oriented now to the general dentists mainly, okay? And if I ask now each of the audience, general dentists, periodontists, or a surgeon, whatever, how would you deal with those cases of the alveolar bone deficiency? I'm sure that each one of us will give a treatment plan from his own perspective, means from his own perspective related to his background training. The periodontist may go to another plan, the surgeons may choose another plan, but all the roads lead to Rome. But each of us will go on for a plan. Of course, the guided bone regeneration is the first line, which is the mostly used by all dentists. And it's the salt and pepper that they added on the bone with those granules of salt and pepper. And the more advanced of them, they cover it with the membrane, lots of kinds of membrane to make this cooking very well. Some of them may add some sauces like PRF, PRGF, whatever kind of growth factors, BMP, to achieve more better healing, or what they think that it's a better healing of that. And the more advanced cases, they may add those sashimi lovers may add some connective tissue graft over those implants to solve those kind of of the alveolar bone efficiency. But to be honest, still, the guided bone regeneration using all kinds of membranes or barriers that they come in fancy boxing and they come so expensive, and all the other graft materials, either allogenic materials, xerogenic, or alloplastic materials that they come in those fancy boxes. All of the dentists, they are fond of using those. They love to use those, and the companies would love more to sell more of that material. And in fact, if you ask me the most difficult question, which is the best material you choose of all? I would say that this is the most difficult question I would like to answer. And it may take me a webinar of 3 to 4 hours to give all the specifications, when and how and why to use each kind of material. So in my presentation today as a concept, I'll just concentrate on the golden standard that I believe in. And this is a fact that everybody believes in this kind of gold standard, which is the autogenous bone. It's recommended by all the big names, all the authors like Danny Boozer since 1990. They published so many papers about all the benefits of using the autogenous bone graft. The main thing, it's osteoinductive, it's osteoconductive, and it's osteogenetic, which is by just using the autogenous bone graft, you are able to create a much better bone in a faster healing time. What I believe in my concept, which I'll show you today, is that nothing builds bone like bone. All the materials, they work well. I don't want to criticize any other method or really any kind of material. I use them all, but still the golden standard is the autogenous bone graft. Maybe most of the general dentists would say, well, doc, it's really difficult to get this kind of autogenous bone, which is usually needs more surgical skills, and it's usually obtained from the chin or the retromolar area or the ramus or whatsoever. I want to show them that you can easily use autogenous bone graft according with the limitations of your skills. But use this kind of graft because it's the cheapest, it's the most biologic, and it's the most effective material, most predictable, and most reliable. Of course, if most of the dentists, they are using the GPR procedure as their main way of treating the efficiency in the alveolar bone, I would say that you can collect particulated golden autogenous bone simply from intraoral sites. The first choice is through your drilling site. Do not waste those very valuable particles, bone chips particles. Don't throw them in the suction. Don't let the suction suck those particles. You can obtain easily. All the dentists, they are used to do simple extractions. You can easily obtain from the tuberosity, from the nasal spine, from the retromolar area, and I will show now how easy even for the general dentist to use the particulated autogenous bone graft as the graft of choice in their augmentation procedures. Just simply regulate your micromotor to a very low speed with between 40 to 100 RPM without irrigation, and get all this valuable bone through your drilling site, which we can use it as an augmentation material over our implants. And this is thumb rule number one. Please do not waste those. There are other very easy procedures that every general dentist can use. The safe scraper on your right side is a very easy and a very effective tool of obtaining corticocancellous bone chips, particulated bone, from anywhere near your implant site population. On your left side, you can see the auto chip maker. The auto chip maker is a very easy, predictable tool to obtain corticocancellous autogenous bone graft just by very small incision, not more than 1 centimeter incision in the retromolar area, which is all dentists can do it. just by obtaining this kind of material. So the guided bone regeneration with the biologic bone is mainly indicated in the correction of minor bone deficiency around implant sites where not effective proper initial implant placement. And this is mandatory, that you should place your implant in the 3D optimal position regardless of the available bone. You can create bone. So like this case, and I will show you, this is one of the very old cases where I used here, I didn't even drill. I just used the condensers to place my implants. As you can see, I stopped the depth of my implant on a 2 millimeter away from the CEJ of the adjacent implants. So this area of the implant site here is still exposed. Of course, I could have placed the implant deeper, but this is incorrect. We have to place our implant in the absolute correct three-dimensional position. Now, there is a small amount of exposure on our implants. With just extending our flap 1 centimeter more, we are able to safe scrape with the safe scraper from the base of the alar nose, from anywhere which is you feel that it's near to your implant preparation site. And the safe scraper, we can obtain very reasonable quantity of bone to correct such minor correction around our implants. So there is no excuse anymore that we cannot place our implants in the correct position. Just placing a membrane, covering all this area, and even one of the advantages of the autogenous bone chips that even you can just suture your periosteum or your flap even without using your membrane, and it will work. Using a membrane like this case is optional. You can fix your membrane and final fixation, and the result is great. Then the final aesthetic outcome is superb just by using the autogenous bone graft, particulated. This is another case where there is a full, almost total labial loss of the graft material. Of course, every case we suspect that we are going to or we have a deficiency in the bone and requires augmentation. That means we have always to raise a flap. There is no flapless surgery with augmentation cases. Okay, so we raise a flap, and as long as we raise the flap, always try to get your autogenous bone chips or bone particulated bone from the nearest site of your implant preparation. So in this case, I have a loss of the labial side. I go to the nasal spine, which is very near from my flap. I can collect from my nasal spine a good amount. I crush it. Even you can scrape it if you don't want to, if you don't have the bone mill. With one strike with the chisel, I'm able to obtain the real biologic bone, crush it, add it on my deficient area, even without covering with the membrane, and the result is great. In some cases where the final aesthetic outcome is of primary concern, and even if we have width to place our implants, in those cases we are obliged to do some bone augmentation. We are dealing with a deficient. Here is a deficient alveolar bone. We have space to place our implants, but if we place our implant just by placing it, there will not be a correct aesthetic final outcome. This is an example of one of my old patients. She came to me, she had the bridge. She had a porcelain fused to metal bridge, and she was at that time one of the very rare patients who came to me, and she asked me, Dr. Salloum, please, I want to place an implant. Because usually they don't come and ask for implant. We suggest and the implant as a treatment plan. But she came to me asking for an implant. And she thought that just by taking out the bridge and placing the implant, she will get a much better aesthetic result. If we look at the case, of course, all dentists could have changed this old bridge with the new zirconia or an AMAX bridge with a better aesthetic result. But the main issue is not the material of the bridge or the design of the bridge. The main issue is the depression that she has here. It will not affect placing the implant, but this is affecting the aesthetic outcome. And look at the depression, all the area is totally depressed. So one of the main things I told the patient that we have to do an augmentation. We have to widen your alveolar crest. Of course, we can do augmentation with the implant, and we can do some kind of expansion. And expansion of the alveolar ridge is cost effective, doesn't cost the dentist any penny, okay? Just do not take out the bone. I show cases where I took the bone from the drill. Here, I do not drill, just the pilot drill, and then try to condense or expand my alveolar ridge, which is indicated where I want to reduce the undercuts. And only by this method, I could gain 2 to 3 millimeters of extra wide. And at the same time, I'll be improving the bone density type. So I will get a much better primary stability of my implant. Of course, using the denser burrs is also a very effective way to do the expansion according to the protocol, and the dentists, they have to learn the protocol, which is very easy to learn, and they can overcome all the problems of the deficiencies in the alveolar bone. It's an easy procedure. Every dentist can use it. Just do not take out the bone. If you take out the bone, collect it and use it. Either you do not take out this bone, just condense it and use it, and you can expand the ridge. This is the case after doing the expansion, and it's very clear how much this curvature has been diminished. So in this case, just adding some safe scraper, additional bone. This is autogenous, scraped from the area, from the nasal spine, put a membrane, and this is the final outcome. And look at the contour of the gingiva, and look at the final aesthetic outcome, just by simple expansion and adding some autogenous particulated bone graft. Of course, in some cases where it's a very old extraction site, there's no place, there's no space to put your implant. We have to do the augmentation as a one step, and then do our implant at a later stage. At a later stage, I'm now still talking about guided bone regeneration, which is applied by most of the dentists. So, like in this case, as you can see, it's a knife edge. It's because the extraction had been more than 3 years. It's a knife edge. We could not place the implant. But as you can see, I just extended my lingual flap 1 centimeter more to expose the storus mandibularis, which is a valuable source of autogenous bone graft. And I just simple scrape it. Use the scraper. You can take a large amount of this valuable bone and use it as a guided bone regeneration procedure. Place it in place. Place it. Cover it with the membrane of choice. This is a titanium reinforced PTFE membrane. And after only 4 months, and this is the main advantage, 4 months are more than enough to get this result of bone, which is able to receive your future implant. In other materials, you cannot obtain the same kind of real mature bone after 4 months. You need at least 8 months to 1 year to get this kind of bone. And this is one of the advantages. For more experienced dentists or who have more surgical skills, I mean, or they are trained a little bit more, they took courses. Of course, the onlay block graft is a very predictable way to do your augmentation before placing your implants. But never place your implants without doing the augmentation, and put it, sorry, place your implants where they should be prosthetically driven. In case of we have a lack of bone, there are so many methods to correct this. So taking only block grafts, autogenous block grafts from the chin and the ramus had been described long time ago by Linkau and by Carl Misch. Carl Misch advised the taking from the retromolar area or from the ramus, and Linkau advises from the chin. Each one of them, they have the advantages and the drawbacks. But most of the cases now we are taking from the ramus or the retromolar area, which is most usable. It's an easy procedure, especially for little bit trained dentists, and by using the new technology of piezo instrumentation. It made everything easier for the general dentist. Taking those block grafts are not a heroic job as they used to be a long time ago. Now, every dentist with the full training course for that, with using the piezo devices, are able to use those kind of technique for correcting such kind of alveolar bone deficiency. Of course, there are limitations and there are special cases how to prepare your recipient site. Before taking the graft, we just prepare, we harvest, and we clean the area from all granulation tissues, and we even little bit decorticate if there's a cortical bone. And I use the piezo devices mainly for all this kind of procedure. Is more predictable and it's safer and it's more efficient, even takes minutes more, only just minutes more. And then according to the size of the defect, I can obtain a small block or exact the size of the block that I want from the chin, utilizing the piezo device, fix it in place, fill the void with the autogenous bone graft material, and everything will be done. This is a case that have a knife edge. We couldn't place the implant before we make our augmentation procedure. The best site to take your graft from is the nearest site from your implant place. So I'll be placing the implant or I'll be doing the augmentation in this area. The nearest part is the chin. So I take my block from the chin, place it, and fix it. 4 months later, only 4 months is more than enough to place your implants and get the result. Of course, those blocks can be used for horizontal bone deficiencies as well as vertical bone deficiency. And this is the advantage of the blocks. And it's very well, and this method is very well documented in the literature. You can use it, as you can see here, the case. This is the case we have to augment this ridge. The nearest part to get the block from is the retromolar area. So we harvest our block from the retromolar area, fix with the screws, and this is the final result. As I said, all those techniques are very well documented with a high success rate. The third technique I want to show is the ring technique. What I'm showing is only merely autogenous, merely biologic bone engineering. The third technique is the ring bone technique. And the ring bone technique had been invented by Bernhard Gissenhagen with his nephew, Dr. Yüksel. It's taking a ring from the chin. I'll show you the technique now. The concept is taking the ring. And the main advantage of this technique is it will allow us to place the implant simultaneously with the block graft. And this is the main advantage of this technique. And it's mainly indicated for vertical bone augmentation. As we see, we take a ring with the special tree fine. We encounter the borders according to the size that we want. Special tree fines are designed for that. Before taking the block, we do the first 3 drillings of our implant site preparation. So we drill inside and then obtain the ring block. There are special remits.
Emad, excuse me.
Yes. Yes.
Sorry for doing that. You are host now. Some of our participants want to join. May you add them? You are
Yes,
host.
sure.
Can you?
Yes, yes, sure.
Okay. Sorry. You're host.
Mostly welcome.
Okay.
Mostly welcome. So,
thank you.
There are special reamer that they accommodate with the same tree fine that we took. And this is the technique of Dr. Kisenhagen. So when it's trimmed, the same ring is adapted to the recipient site, and the final drill of our implant is inserted, and the implant is inserted in place through the ring and through the preparation site. So the advantage is to do the augmentation, the vertical augmentation, and the implant placement at the same time. As we can see here, the only drawback of this technique is that it is not designed for every geometric design of implant. It was mainly designed for the ankylos implant. As you can see, the implant was inserted, and the compression of the implant design threads is responsible of stabilizing this bone ring. Of course, now it's available in the market. A lot of implant designs may accommodate, and they are applicable with this technique. Some voids could be filled with autogenous bone block, bone articulated, and the end result is superb. One of my favorite and the last technique that I would advise, but it's made for more experienced dentists, more experienced, and it's mainly used by surgeons or highly surgically skilled dentists who are mostly interested in doing such kind of the augmentation for the complicated cases, is the Khoury plate technique. And the Khoury plate technique, for me, it's one of my favorites, and it's all autogenous. What I presented until now, it's only the golden standard. I love gold. The shine of gold is beautiful, and the appearance of the particulated bone graft, autogenous bone graft material, you will love it. Of course, I don't know why. Okay.
Okay.
The main principle of Khoury plate is to obtain an autogenous plate, which is thinned and trimmed to a thickness of 1 millimeter and fixed with screws, with the space between the recipient site and this plate. And this space is filled merely and only by autogenous particulated bone, which is obtained from the scraping of the same block that we take. Professor Khoury invented special micro saw to do that, but now I usually do it with the micro saw either or with the piezo device. And after getting this block graft from the retromolar area, it's a very safe area. Just it needs training, special training for that, and every dentist who is trained to do it, I'm sure he is able to do the same technique. But after getting the graft, this is a case where we should augment this part. We should augment this part. The nearest part, so I take a block from the retromolar area as a Khoury plate. After getting the plate, the principle of the Khoury plate is to split it. This is the thickened plate. It's Some people may say that this is an invasive procedure. Believe me, this is less invasive than taking out an impacted third molar. Impacted third molar is more aggressive than this technique, believe me, and less edema. Okay, this is the block that had been harvested from the retromolar area, and the principle is that this block has to be splitted in two halves. So we can use the two halves. It's like taking out like a split of a piece of a bean or something. This is totally splitted, and when it's splitted, just by hand pressure, I'm able to split and transfer one block into two plates, which have to be then fixed. As you can see, easy procedure for the trained guys to do it. Then this plate is scraped inside by the safe scraper to collect as much as particulated autogenous bone, leaving only 1 millimeter thickness. And 1 millimeter is more than enough, okay, according to Khoury's recommendation, fixed with 2 screws, and the void area is filled with the autogenous particulated bone that had been collected by the safe scraper. Of course, we can collect more spongeous bone from the same area by using the safe scraper or the auto chip maker. We can still obtain some more autogenous bone graft material added to the area, and without any membrane. We just close the wound, close the flap in a watertight closure, and the healing is perfect. This is another case. It's it's a horizontal bone deficiency that we cannot place our implants. Khoury placed are obtained. This time I'm showing from a piezo as a piezo device. Khoury place is easily obtained from the retromolar area. And this is a real-time video. I want to show you that doesn't take so much time in experienced hands. Very minimal trauma. And after doing this kind of splitting, just one knock with the special blade-shaped chisel, maybe at maximum 2 knocks, and this block is separated easily, as you see. Now the block is separated. Then it's splitted into 2 halves. Just simply split it from all around the area, and there are special discs, so we can do it. One slam with the chisel is enough to make the splitting, and those 2 plates, they are scraped again from the inside, scraped, and then fixed away from the at a distance from the recipient side. Usually we place it about 5 millimeter to 6 millimeter and fill this void area with autogenous particulated bone graft. And 4 months later, just we have to ensure a good closure flap, and this is mandatory in all kinds of surgery, all kinds of augmentation procedures, especially if the dentist is using foreign materials. I mean, alloplastic materials, titanium mesh or so. This is more even important. With the autogenous bone, particulated bone graft or the Khoury technique, still the flap dehiscence is little forgiving, is somehow forgiving on an autogenous block. This is the final result. This is 2 weeks post-op, and this is 4 months post-operatively, only 4 months. And you can see the blanching of the mucosa because I gave the anesthesia, okay, the infiltration anesthesia, and after 4 months, you'll get this size of mold, which you may not get the same result with any kind of other alternative material, at least in my hands, or at least what I believe in my concept. Of course, using allogenic bone blocks now is becoming more popular. Because some patients or maybe some dentists may not agree to get the patient into another surgical site, which I believe it's not. And sometimes I do like 2-in-1. If the patient has an impacted third molar, I do it free of charge and take all the block over the smaller. So I make it 2-in-1, and I take the advantage of taking the third molar out and taking the block. But using allogenic block grafts is becoming more popular, and we have to wait more for the results. But still, you have to know that the allogenic materials, all kinds, they are osteoconductive, they are not osteoinductive, and they are not osteogenic. So you have to wait longer time to do, and in case of failure, you have to go back through all the procedure again. This is my final case I will show you. It's a kind of modification of Fori plate technique, which I really admire one of my mentor for naming it. It's called allogenic block technique. It's modified by me. I will show you the case. This is the case of my patient. As you can see, she had the severe vertical bone deficiency. And I will explain why. She is a very old patient of mine. She had an amyloblastic fibroma maybe 20 years ago. And I placed, and she had a total mandibular hemisection. And this is the wound, as you can see. And after 15, maybe 18 years, I don't quite remember, she came back to place implants. And there was a resorption in the elia crest bone graft. And as you can see from the panoramic X-ray, from the CBCT, the difference between the two sites. So I decided to place my implants. And this is the real modification. I decided to place my implants simultaneously with the vertical bone augmentation. And as everybody knows that the vertical bone augmentation is the most challenging, really, augmentation. So I'll start with the incision. After obtaining all my PRF plugs and my PRF membranes, I expose the bone. And in this case, before dealing with any kind of augmentation, I have to ensure for releasing the mylohyoid muscle and releasing the flap to ensure after later closure that I have enough tissues to achieve total closure and non-tension, total watertight closure. Then I used my surgical guide. It was a simple surgical guide. I marked the place of the implants. I placed my implants, and as you can see, there are about 5 millimeters of my implants are left exposed over the available bone crest. And this is the case. I placed 4 implants. All 4 implants were only inserted in the available bone for only 5 millimeters. So I left all of them, they were 10.5 millimeters. So 5.5 millimeters were over the crest, available crest. And this amount of space I have to build it. I'm using here allogenic struts, which I've been using now for quite a time. All the struts and all of the allogenic material, I actually obtained it from Iran. It's a great material, and it's with a very high success rate, and I've been using them now for more than 5 years with excellent results. So I placed the cortical strut over the implant and fix it with the cover screw of the implant. In fact, they are not the cover screw, they are the healing collars of those implants. And this available space, I will fill it with autogenous, particulated autogenous material. Obtaining the autogenous particulated bone is easy here by using the auto chip maker and mix it with the PRF to get a real good amount of sticky bone. I filled the sticky bone around the exposed part of the implants. And as you can see that this strut is, the level of the strut here is the coronal level of the augmented area, and all the rest will be filled with autogenous, particulated autogenous bone mixed with the PRF to make a sticky bone. And now I will add more drops of IPRF, which is the injectable IPRF, as recommended by Shukroon, to make a real sticky bone in this area. Then we will I covered all the area with the PRF membranes just to give better healing. Of course, maybe a lot of people would ask me, would you believe that it would get a better healing for the bone? I would say there is no solid proof until now that it affects the bone, but I'm 100% sure, and all the research shows that it's mandatory for the soft tissue healing, which is very important if there is a good soft tissue healing, so you are maintaining your augmented area beneath the soft tissues. When it's a good healing, so the essence is in lower risk. So this is the final layer of the PRF, and here you can see that the flap is a tension-free closure after dissecting the superficial fibers of the mylohyoid muscle, and by doing a release of the labial flap, horizontal mattress sutures on 2 layers, which we call by Shukroon, it's called the apical mattress sutures, which are mandatory. I'm sorry here for this shot of the video that shows that even if I move the cheek, the edges of my wounds are tight, are not moving. 4 months later, you can encounter this amount of autogenous bone had turned into real biologic bone, and the end result of the case is this is after 4 months, and the patient is ready for the final prosthetic work. And as you can see, our bridge is in the exact limitation of the best prosthetic option that we have. If you can see that if we didn't make this kind of augmentation, I think that the implant prosthetic ratio will not be correct. So by this means, look at the case. I think that everybody would really appreciate the final end result, that after the augmentation, the patient had a nice predictable result. I'm sure now, I think that all the audience may start to ask me. So I want to make it in advance. Everybody would say that you showed us several ways, several concepts of autogenous biologic bone. Which one would you prefer, or which one you think it's the most effective? Which protocol is the best? Everyone will ask me, what is the most successful way of all those procedures? What is the best bone substitute graft material? And this is the always traditional question that I get. And what's the survival rate of the implants in the augmented, all the grafted sites? I don't want to share you my opinion. I will go to the research. Simon Johnson and his co-workers made a review, and that was published in 2009. It's not new. This is published 2009. They reviewed more than 2,000 abstracts and more than 424 full text regarding all kinds of grafting materials. They reviewed all the results of all kinds of materials. And the end results for them was the available data did not show one superior grafting protocol over the other. And the survival rate of the implants which are placed in the augmented areas, are really comparable to the survival rate of the implants, which are placed in the real bone without augmentation. Because this bone, after augmentation, 4 months after augmentation, they all turned into real mature bone. It's totally replaced, and now it's a mature bone. So the survival rate is comparable even to natural, as if you are placing implants in the natural. Another study done in 2007 and 2006, I would like to show you that they all recommended that autogenous bone transplantation or as a graft material is the most effective method. This is not my opinion. This is not my concept. I'm giving you research of 2,000 papers. And if you want to choose some other materials for some kind of augmentation, those papers recommended using beta-3 calcium phosphate granulation tissues as a highly reliable bone substitute material. Of course, it's an alloplastic material. And the main advantage of it is that it's totally resolved between 6 months and 1 year. It's not like xenograft. Xenograft may last for 20 years, stay, and really, xenograft is not turned into real bone after even 15 years. I've seen cases, still the same material of the xenograft is available as it is in the same site, while the beta-3 calcium phosphate is totally resorbable and is totally replaced by new bone. So it's a scaffold, or it's osteoconductive material to make a new bone. My conclusion for you, I don't want to make a long discussion, so I will go for the conclusion that all kind of biologic bone engineering, either if you use it as guided bone regeneration, bone blocks, or the ring bone technique, or the Fourier plate augmentation, are all common and very predictable. And the most important is not only predictable, they are reproducible. What I mean is reproducible, that it works every time. It's not 50-50. It's not a 50-50 chance. So they are reproducible surgical protocols that should be considered by the general dentists as a part of their treatment plan. They should put it as a treatment plan. If they are capable to do it, I think that most of them, all of them, they are capable to do all kinds of using the biologic bone as a GBR procedure. And I showed them how much it's easier through the drill, through the safe scraper, through the auto chip maker obtaining. It's a very easy procedure. If you are more skilled, you can go for more sophisticated procedure. I have two take-home messages for my audience. One take-home message, the first take-home message is, I will transfer it from Dr. Sir Howard Pine, who was a dentist, very well-known, famous dentist, and he died at the age of 94. He died in 2009, and he was from the generation who witnessed the first beginning of the implants, of the dental implants, and he went through all the new innovations in the implants. And he used to teach a lot of dentists. And his take-home messages was always, please set the teeth where they were born. Do not set them where there is bone. So please place your implants where they should be placed from a prosthetical point of view, where they should be, where they were born. Do not place them where you find bone. This is the first take-home message. And my second take-home message, after you saw all those kind of protocols, please just think that all kinds of augmentation, all kinds of bone engineering protocols, they are biological concepts. It's not a carpenter work. We have to understand the biology behind each material we use. We have to understand that the healing process of each surgery we do, and this is mandatory. And we have to know that there's no one treatment modality that fits for every case. So we have to get in our toolbox several ways or multiple management modalities should be ready in our toolbox, ready to be used for each case. And for each kind of protocol, please follow the rules and never intend to make shortcuts. If we make shortcuts, we get more failures. And if you want to make shortcuts, you have to master and master and master the rules first, and then try to innovate something new. And when applying a technique, please do not apply it if you don't know how to handle its complications. And always do not be attached to one technique. I showed you a lot, and they all work well. Even with other materials, they work very well. So do whatever works best in your hands. And this is my take-home message for you. And I say that all those techniques, they appear to be user-sensitive. So please take training courses. Advanced training are highly recommended. Please do not open YouTube's videos of surgeries and think you are learning from YouTube. YouTube and Facebook, they are informative platforms. They are not learning platforms. If you want to learn any kind of technique, go and take a course. Go for the real educational platforms, and then you go and learn this technique, and you can proceed with it in a very safe way. There are training courses all around the world with different colleagues all around the world. I have my training courses. I'll be more than happy to host anybody, everyone to be in one of my courses one day. They are mostly welcome. And my courses are approved with the Bird Academy and the Dental XP. And till that time, till we meet one day, somewhere, someday, I'll ask you all to stay home and stay safe. And thank you for your kind attention. Any questions, I'm ready to answer through my email, through my website, my Instagram. All are mostly welcome.
Thank you. Thank you so much, dear Emad.
Thank you for
fantastic. Let me reclaim host. And
okay.
Yes, thank you so much. I have something to say about your fantastic and impressive lectures, but let me show you, ask you some questions from our participant first, then I talk again. Dr. Emad, Dr. Soya asking that with the splitting technique of Dr. Khoury, we get one side more cortical bone than the second splinted part. When we use in two parts. It's not affecting the outcome?
Absolutely does not affect the outcome, because those thin plates, either it's a cortical side or a less cortical side, both of them will work as a barrier. The real bone constitution of the side is the autogenous particulated part. So this is the real bone which is going to be turned into mature bone. Those two cortexes, they are just a barrier to protect the underlying autogenous from getting the pressure of the flap. This is the main goal of those.
Right.
That's why we make them as thin as possible, not more than 1 millimeter, just enough to hold the screw so they don't break if you just insert the screw.
Right. And again, regarding Khoury technique, another doctor participant asked, should usually be used the autogenous bone with the Khoury technique?
Khoury technique, as a technique, the concept of Professor Fuad Khoury is using only autogenous bone. No other bone is used by the technique of Fuad Khoury. And he believes, and he has, and this is very well documented in the literature, and this technique with autogenous is always predictable and reproducible. And it works every time.
Yes.
Every time it works. So, no. They
Exactly.
need only autogenous. My modification through my technique, what I showed you here, just small modification. The first one is using an allogenic struct over the augmented area. And the second modification is that placing my implants simultaneously. This is the only. But the concept is still the concept of Professor Fuad Khouri.
Okay. Also, Frank Zastro said that again. That
Absolutely, yes. Yes.
autogenous bone for
Yes.
biologic bone formation. Yeah, autogenous
Yes.
bone is
Yes.
perfect for that.
Frank uses, he is from the same school of Fuad Khouri, and he was, Fuad was his mentor, and he uses only autogenous
Yeah,
bone.
bone. Great. Thank you. Very fantastic and impressive lecture. Thank you, Dr. Emad.
Thank
Yes,
you for
as you
you.
said before, among three predictors for success rate, implant-related or system-related factors and patient-related factors are very important, but the most important one is clinicians' experience and knowledge in success rate. So
Yes.
as you said, they should increase their knowledge and experience and getting better and better to do these techniques. And the most important one uh, about the techniques, they should know who you need to be for doing these techniques, for utilizing these techniques. That person is very important to use the other part, use other techniques and different materials, different techniques. But that
Yeah.
person is very important. Who is he? Who is
Yeah.
she?
Absolutely. And they have, everybody should know that there is a learning curve for everything. We all started, even me as a maxillofacial surgeon. I took the courses of Fuad Khouri. I took all the courses of the bone ring technique. I didn't I didn't do it just by because I saw a video. No, I took courses, I attended special courses for that. And after that, there is always a learning curve. There is always, every time I do it more, I get more experience and but from the first time after doing a course, every dentist should be able to do it in a correct way. But it makes sometimes some hints, some tricks that you can master it with experience.
Yeah, exactly. They should uh, gain their own skills level and then can learn from the others first.
Absolutely.
Yeah,
That's why I always advise sharing cases. What I mean that if we are three, four dentists in the same group or the same community, and if we will, if each one of them will only depend on his own cases to learn from, there will not be enough cases. If a group of four or five share together each case for each one of them in his office,
mhm.
the other group would come and join, share the ideas, assist with them. So they will get accumulated experience.
Great.
And go and attend congresses, go and attend the training courses. All it will make you more confident in doing those kind of augmentation procedures.
Exactly. And prepare themselves as a self-development, their concepts, their vision from efficiency dentistry to effective dentistry, their character, their team, their brand. Yeah, it's very important. And then they can use from the others. Also, Dr. Emad, we have another question. Uh, Dear Dr. Emad, thank you so much. Could you briefly mention about how you're preparing the recipient site or host before Khoury's technique, like preparation, the host bone or more, something like that? The preparation site, how's the recipient site? How you to prepare recipient site? Dr. Emad, can you hear me? I think we lost Dr. Emad. Uh, Dr. Emad, are you with me? Can you hear me? Dr. Emad, can you hear me?
Yes, yes. I'm sorry for the interruption. What happens? Yeah.
Okay. Yeah, we are facing with these problems so many times. Don't worry. Another question. Dear Dr. Emad, thank you so much. Could you briefly mention about how you prepare the recipient site before Hori's technique?
Well, okay. Any recipient site, regardless of the technique you are using, has to be prepared very well, which means it has to be free of any granulation tissues, free of any inflammatory tissues. And in some cases, either you decorticate it, or you penetrate it. But in Khoury technique, there's no need to decorticate usually or perforate. Perforation is an optional, but the main issue is that it has to be absolutely clean from any sequestrums, from any inflammatory tissues, from any granulation tissues, and it has to be a total, pure, solid, clean bone. And this is the main issue. And you have to trim adjust the borders. So in case you are using a block graft, trim the edges in a way that you can place your block graft exactly that fits very well with the screw.
Okay, thank you so much. So I think there is no other questions. Okay, thank you so much, Dr. Emad, for this amazing, impressive lecture. Yeah, thanks you. No, there is no question anymore.
There are no questions.
Okay, it was my.
I would really appreciate. Thank you, Mizyar, for hosting me, and thank you. And I am really looking forward to meet you again, to see you again somewhere in the world, sometime. Yeah. It will be a great pleasure. And thank you again for hosting me. And I would really appreciate, and hats off for you for this forum, Implant Diary, which is totally devoted for teaching, for sharing knowledge and sharing ideas. I really appreciate your work and wish you all the best all the time.
Thank
and
you.
Hope to see you again soon.
Dr. Emad, hope we meet each other in real world, not virtually.
Yes, real world. Yes, that's what I want.
But it was a pleasure for me. It was a delight, great delight for me. Thank you so much. And thank you all of you, my friends, participants for joining.
And thank you to all the participants who attended. Thank you for them all.
Stay safe.
And hope to see you all again. Stay safe, please. Stay safe and take care.
Thank you. Bye.
Bye-bye.
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 Bye.